Ladies and gentlemen, honored members and guests, Professor Buchler and DiCarlo. My task today is to discuss pancreatic-jejunal anastomosis and risk factors for fistula. First, let me outline what I'd like to talk about. The ideal pancreatic anastomosis on the short term does not leak. But on the long term, for months to years, it must preserve exocrine function as much as possible, and it must prevent development of diabetes. If these three items are met, you have as close to a perfect anastomosis as one can make. Let me focus on the long term for a minute, particularly preserving exocrine function. Several years ago, we published a paper where most of the patients that present with pancreatic head cancers are exocrine insufficient. Some 32% had normal exocrine function. And any malignant tumor, about half the people would already be exocrine insufficient. But in those that had normal exocrine function preoperatively, how often did the Whipple procedure preserve the exocrine function? This is what we found, that about half of a person's normal exocrine function is lost by a Whipple operation. And it's seen at 3 months, a decrease, and if we looked at the patient at 1 year, decrease, and at 2 years, a decrease in exocrine function. Yet, if one did a distal pancreatectomy, not a Whipple, all the people with normal exocrine function would retain their exocrine function after extended distal pancreatectomy even. Clearly, Whipple operation and its anastomosis interferes with that exocrine function. Now, let's look at preventing development of diabetes. Let me call to your attention this paper from Milan and from Rotterdam, and they showed that in a group of patients that had pancreatic-jejunalostomy or occlusion of the pancreatic duct after a Whipple operation, a difference in these two types of operations for pancreatic fistula, abscess, and diabetes at 3 months and 12 months. And here's how it went. Pancreatic fistula, higher after occlusion. Pancreatic abscess, about the same. Diabetes, higher after occlusion. And at 12 months, still 1/3 of the patients diabetic were those with a pancreatic-jejunalostomy maintained most of their endocrine function. So, with those two items in mind, let's go ahead and discuss the pancreatic-jejunal anastomosis and the risk factors for leak. That is, the short-term outcome. But that's just one thing that we must accomplish is in the perfect anastomosis. Let's talk about the short term. So if we're going to make this pancreatic-jejunalostomy, now I'm pointing out the biliary anastomosis, but if this pancreatic-jejunalostomy is going to not leak, what do we have to do? What does leak mean? And how best to improve our leak rate? And that is by controlling the risk factors. The fact that this anastomosis does not leak is, as discussed by others today, there's a huge diversity in the definition, particularly in grading the clinical severity of the leak, which is more important than whether it leaks or not. Then the incidence of leak is low, and every series is low. 1/4 of the patients or less will leak. And therefore, to study a patient cadre in order to see if your technique is better, one must limit the cases that are being studied to those that are going to leak so that you don't need as many cases to come up with an answer. So, diversity of definition and grading clinical severity. Thanks to the International Study Group for Pancreatic Surgery, we don't have that problem today. Because before that, we had leak rates reported all over the place, Drain amylase elevations were of a multitude of definitions, as listed here. Drain volumes were either not defined, or they were 30 mils a day or 50 mils a day. And then what postoperative data started measuring? Nobody really knew. This is some of the items that were in some of these studies. So thanks to Claudio Bassi and his co-workers, many in this room today, we now have a definition. And in fact, we made it so easy for a person to use a standardized definition. If you just go to the Pancreas Club website, go up here to calculator, click on the calculator, and one will get this list. Fill in these 13 blanks, and at the bottom it'll automatically calculate the fistula rate and A, B, or C, and the delayed gastric emptying and A, B, or C. And it's all done the same way. It's web-based now, easily available. But let's move on to the incidence of leak is low and how we can limit the cases to those at risk to leak. Some years ago, we published this paper where we used a surgical microscope to reduce our rate in Seattle. But during that study, we found that the leak rate was directly related to duct size. So if it was a 1 millimeter duct, the leak rate was close to 25%, where if it was a 5 millimeter duct, it was 0. And just recently, we're looking at our database, we found this correlation. As the duct size increases, the leak rate decreases. And also, that goes along with if you grade them to A, B, or C, according to the ISGPS method, decreases as well. And there are only a couple of grade C fistulas in these 413 cases. This paper is presented in print this month in surgery. Professor Buchler referred to it. And let me use some of the information in that study to outline the risk factors for leak. First of all, these are the risk factors that were found in multivariate analysis in that study of 507 cases. They're all done the same way. And the risk factors were as those listed on the left column. I'm going to go through the odds ratio to give you an idea of how important each one of these risk factors are. And I'm also going to, this is any leak, whether it's an A, B, or C leak, that is any amylase in the drains, according to the ISGPS classification. And then here are the significant leaks on the right column. So these are any amylase in the drain. This is just the significant leaks in the right side. So if you're a man, your risk is twice that to have amylase in the drains. 4.5 risk increased if it's going to be a significant leak. Soft gland, well, this is pretty well known, but it's real difficult to say what a soft gland is. You might say one thing, and the next person would say, well, it's firm to me, and so it's sort of a subjective thing. Body mass index. Well, now here is something we cannot control, but it's something we have to deal with every day. Using 2.5 power versus 12.5 power, one is with loops, the higher powers with the microscope, showed that there were there was an increase of 3 times if one used loops and didn't use the microscope. But there was no difference for a significant leak, which means to me that if one has a amylase in the drains, that there's more to it that goes in to make a significant fistula than just amylase in the drains. If you want to stop amylase in the drains, the microscope will decrease those odds by 1/3. Now, main pancreatic duct being less than 3 millimeters in size, a huge odds ratio for that, having drains with amylase and having a significant fistula. So you remember that as the ducts get smaller, the risk gets higher for having a leak, whether it's a significant leak or just amylase in the drains. This is the area we need to focus on to study our techniques. How good is this technique? used the patients that are at risk to leak only to study. So we took a subset of those patients, this is unpublished data, we took a subset of those patients that just had small ducts, 3 millimeters or less, of which there were 283 over here, and compared it to those that had ducts greater than 3 millimeters. We found this. 11% had a significant fistula, that is a B or a C leak. Why, if it was 12.5 power, then 8% had a leak, and if it was 2.5 power loops, 14% had a leak. What about the ducts that were larger than 3 millimeters? There really wasn't any difference. You can do anything to these ducts, they're not going to leak. Those are the ones we really don't want to study. But what about those that were really small? 16% overall had a leak, but if one used the microscope, you could lower the rate to 11% in those at risk versus 21% using surgical loops. This is the area that shows, by using the small ducts, it shows that a technique has a chance of making our results better. And in fact, if the surgical loop is a mystery to you, this is what happened to my results when I started using the microscope. The ABC leaks, that is, any amylase, were up here before the microscope period. But as soon as I started using the microscope, the next day I went down to here, which showed me that I couldn't see, and that now I could, and I could do a better job. Now here is a duct, which if you look closely, is just 2 millimeters in size. And it's pretty large here under the microscope. But it is the one that's going to leak. So let's go over this. Independent predictors of leak are these items. Which are the ones that we can control as a surgeon? Which are the ones we cannot control? Well, here are the ones we can't control, and the only one left is seeing better, at least on this list. And you can come up with some other ways of making your anastomosis better. But if you take these patients, if you take a man that has a soft gland, that has a body mass index over 30, and a main pancreatic duct less than 3 millimeters, the leak rate is going to be 70% of having amylase in the drains. These are the patients that we need to study in our randomized controlled trials. That ends my comments tomorrow, or not tomorrow, but later on today. I have some new unpublished information from the international database, which shows the leak risk factors for almost 3,000 cases that I'll share with you in a little while. Thank you very much.